Dr. Robert Eastlack will be giving a talk on dynamics of reimbursement using MIS surgery in spinal reconstruction. Thanks, Dr. Eastlack.
Thanks, Chris, Vdara. I feel like the adopted UCSF family up here. So this is an interesting topic, not one that we think about a ton, and a bit challenging in the sense that I'm sure you all run into the same sort of opacity with respect to reimbursement, particularly on the facility side, the charges and costs that go through that area. I really have no disclosures relevant to this other than the conflict I have with payers and government, commercial payers and the health systems. If you look at this problem, it's worth looking at the clinical pathways for MIS deformity surgery, and there are different implications relative to that, including some of the staged and same-day discussions we've had for many years and how to manage those. And then reflecting on what we do with open surgery. There's been a lot of this done in the realm of degen spine. This is a fairly large piece of work that it did looking at open versus MIS posterior fusions, and found with a pretty big cohort that there were lower length of stays, lower UTI rates, interestingly, but not surprisingly, higher hospital costs for MIS. But as you can see in the table, the readmission and the cost drivers there for open were pretty substantial. So secondary hits are to be considered as well. When we talk about the reimbursements and costs of spine surgery, I think it's important to sort of look at how we analyze. Direct costs are the real numbers that should be utilized. They tend to vary less across institutions. There's certainly some variations, but they're pretty tightly controlled numbers. Hard to find them. We've done work on the ISSG side, and we have a fairly limited number of sites that can actually extract that data from the institution. So they like to keep us in the dark with respect to direct costs, but they're probably the most useful tools for real health economics analysis. Charges are what you can see a little more readily. They tend to vary a lot more substantially, but they're more transparent. They're a bit less important for health economics analysis, qualities and ICER analyses, but they still can serve as a bit of a proxy for comparisons and costs when discussing different sorts of approaches. Cost minimization in adult deformity is obviously a big topic. It's a somewhat poorly sustainable economic proposition taking care of deformities. And this is one of the early works done by Rick Fessler's group and comparing MIS and open deformity approaches. I couldn't quite figure out the staged cohort with T-lifts, but nonetheless, that's how they proceduralized. And you can see here the number of patients. You could tell with the table here that they weren't apples to apples deformities, a little less deformed in the MIS subcohort. But nonetheless, one of the things to sort of take home from the paper is that the MIS subcohort generally had fewer levels operated on. The length of stay was substantially different. And when they did their charges analysis, you can see a pretty marked difference in the overall charges, which will translate into some cost differential on the direct costs. So MIS sort of looks reasonably better in that narrative. So when we think about MIS deformity reimbursements and costs, these are some of the factors that I think are relevant. The OR time, of course, is important. There's time value there. And with MIS, is certainly, as it came out, the proposition of the implant costs was quite substantial. The bending of the cost curve for these implants has helped a fair bit, and we'll talk about that in a bit. In general, the work that we've done has suggested that for much of the deformity work that we do, MIS can do this with fewer levels being addressed, and that obviously is a cost driver. There's less transfusions, length of stay, less ICU use, less rehab or sniff requirement, and then again, we'll discuss the stage and same-day impact. The impact of time for surgery on surgery reimbursement is relevant, of course. This was just a smaller look. I thought it was sort of interesting because it took microdisc through lami posterior fusion. And when they really scrutinized the actual flow of money relative to time, it turns out the microdisc came out on top. So despite us thinking that surgeons might go for the bigger surgeries from a personal value perspective, that may not be the proper way to look at it. The value of OR time is real. The OR asset is increasingly expensive with HR costs in particular. This is actually an older number, up to $130 per minute of OR time, and $6,000 per hour is a more recent number. So it is paramount that we use that asset efficiently. When looking at MIS surgery for deformity here, this was more of a meta-analysis, so kind of a hodgepodge of methodologies, but on blend, it looks like MIS deformity surgery allowed for less OR time, decreased DBL, length of stay reduction most likely, and two of the studies actually showed a decreased cost overall. But if we look at today's numbers, sort of real life consideration, and again, I'm gonna use sort of a best I can propensity matching, assuming that we can do a case with fewer levels MIS with a similar deformity versus an open case. And this is a comparison of the MIS data set. Here are some of the relatively current costs. So a sample MIS deformity case would be 4 inner bodies for those levels, graft material. With the bioactive implants now, you can drive down the graft costs in these cases. 10 pedicle screws, 2 rods. So it's sort of an average MIS deformity case for sagittal planar, mild to moderate degen scoli. And total out there at 22 grand. So real direct costs currently, at least for the OR implant utilization and graft utilization. Same case done open is going to typically be T10 to pelvis. Here you might have 1 inner body for the posterior crowd. So I dropped the cost down there for the inner body. Graft materials vary. BMP is a common graft choice. Can be anywhere from 5 to 10. If you're Larry, you might use $20,000 or $30,000 for the BMP. Point is, it varies substantially posteriorly. 20 pedicle screws, 4 rods, cross connectors, and the total there with real direct hospital cost numbers about 25 grand. So, when I started doing MIS work, I think these numbers were not quite as favorable. I think the MIS was considerably higher. But it behooves us to understand those dynamics. So as we're making choices in what to use and how to deploy it, we're doing it armed with data. This is where some of that came from. We did an internal study looking at some of these new implants, realizing that at one point we were using, $4,000 or $5,000 interbody cages with $4,000 or $5,000 worth of biologic at each level. That's not sustainable. So looking at ways to curb those costs, we basically dropped the barrel out on the biologic side of this, and we're able to get a 99% fusion rate or so with essentially no biologic cost per level. And that provides some better sustainability for MIS deformity. As I mentioned, some studies show less OR time for MIS deformity. Really, that's probably a reflection of being able to tackle some of these deformities with fewer levels. When you propensity match in that way, it looks pretty good. However, if you look at a different sort of matching where you do similar number of levels, you do begin to see some attrition or worsening of those outcome variables. In this study, we looked at an open versus CMIS group, and you see here that we had a similar number of fusion levels, and with that, the time escalates with MIS relative to open. So I think if you're going to be looking at this comparison, you have to be really thoughtful about exactly what the deformity is, if you could tackle with fewer levels, and what the time impact is. EBL is a real issue. The this is a paper looking at TXA specifically and it driving the cost down. But even in this paper where they use TXA, the average number of transfusions is about 5 with deformity surgery, which translates into about a $5,000 cost driver on average per patient. With MIS, it definitely goes down. These early papers, granted with milder deformities, essentially had no transfusions. With a little broader group, with our open versus MIS comparison, you can see the transfusion rates were considerably divergent, but there were still some in the MIS group, around 27% versus 71%. And then ICU, also a big deal. I think everyone would agree we use that less with deformity surgery. Neil really popularized this earlier in our learning curve, really seeing no post-op ICU stays. If you look more broadly, ICU stays for a bigger group of MIS surgeons was about 0.6 days versus 1.2 days. Is that meaningful? Well, if you consider the cost can be upwards of 15 grand a day, it might be. It's certainly something to consider in the grand scheme of things if you can achieve your radiographic goals with both. Importantly, these additional costs, whether it's blood transfusions, ICU stays, may not be reimbursed. There's a value erosion in the episodic care costs. The length of stay impact is real, and as I mentioned earlier, the cost of care is going up substantially, heavily on a human resource basis. These are some of the more recent numbers on daily costs of being in the hospital, so the extra days really do add up quickly. If you can drive patients home a few days earlier, it is meaningful societally in terms of the cost of overall care. Mike Wang looked at this in 2010, again, very early in our iterative learning on MIS deformity, and he was also able to show pretty low requirement for skilled nursing facility, obviously less cost than the hospital cost, but not insubstantial if you consider a couple weeks stay. So, how does this all relate to the surgeon? Reimbursements for the surgeons vary relative to the hospital. But if you look at the facility costs here, while commercial payers have gone up, Medicare, government dollars are going down in terms of reimbursement for these types of surgeries. And it's incumbent on us to understand how to optimize reimbursement in these settings, whether it's MIS or open. We looked at this in terms of the way DRG coding is accomplished, and there is a favorability, at least with today's financial model in the U.S., to have an anterior-posterior reconstruction as long as it pencils out on the health system or hospital side. So you can see here with the case type 3 and 3 with comorbidities, there's a different coding that results in a variation and tick in the reimbursement. And the Medicare reimbursements vary by length of stay, 3 or 8 days. But as you see, even at 8 days, you're not seeing a huge uptick in the amount of reimbursement that flows through the hospital. So those additional days don't really get paid for relative to the costs incurred by the health system. So take-home points from this are, number one, there is some thoughtfulness about anterior and posterior reconstructions for these procedures relative to the reimbursement that we achieve. And the fewer days they're sitting in the hospital, probably the more solvent the care becomes, not surprisingly. So what about staging? There's a divergence here as well. The payers and really Medicare, CMS are the drivers of this. Commercial payers are going to follow that. Do not handle facilities and surgeons the same way. We may derive benefit from the staged. Usually we're going to do that with anterior or lateral reconstructions as part of the deformity surgery. An anterior reconstruction with the posterior is going to drive another $8,000 extra to the hospital bottom line. And importantly for the surgeon, there is the ability to recoup the extra costs of your time because you can bill for that procedure separately. You don't get down coded with modifiers. The hospital has to do this all under the same DRG. So It's, again, quite important for the hospital not to stage things 7 days later, because they're going to eat a ton of extra costs waiting for that second stage to happen while they've only gotten one fee for the whole process. On the same day side, you're going to take a little hit as a surgeon. You have to pencil out whether that makes sense with your time value. It certainly might reduce the length of stay. There's some question about complication rate profiles. There are some data suggesting that staging the procedures actually drives less complications for the patients. But I don't think we're to the point of summary judgment on that. So in conclusion, Medicare and private payers, and which there are, which is back in the patient, impact the reimbursement overall. MIS deformity surgery reimbursement is going to tend to be favorable when, as a result of fewer levels needing to be addressed. The DRG scheme, which again is not the entire market, but the market's following that substantially, requires a really scrutinizing use of ICD-10 codes so that you're really gaining the reimbursement that you deserve for doing a deformity operation. You miscode it, you get a huge drop in the amount of money that flows to the hospital. The DRG system currently probably favors the anterior-posterior reconstruction subtly. We'll see how that changes over time. Length of stay over 3 days tends to erode the financial solvency of these surgeries, so be thoughtful about that. The implant and biologic costs are very dynamic. They've changed dramatically over the past couple decades, and I'll have to tell the implant companies that. In the end, it's going to help us be sustainable. We'll be able to continue to take care of these patients if we can partner in that. In general, the less we use the ICU, the better for these patients. It's a huge cost driver in these hospital stays. And then we can reduce the transfusion costs and skilled nursing facility needs. The premium cost structure of MIS surgery implants has to be considered in this equation. So partnering and understanding that within your health system or hospital is really important so that you can be a good steward to health economics. In terms of staged and same-day considerations, in general, the stage is probably a bit better for the surgeon. I think it remains to be seen whether it's ideal for the patients and their speed to recovery or kinetics of recovery. The prolonged staging more than a few days probably is not going to be viable for the facilities given the current dynamics of financial flow. In the end, however, you do what you do best. If you're messing around with things you don't do well because of these kind of financial dynamics, you're probably going to end up driving up costs in some way that's not anticipated through complications or otherwise. So do what you do well. Thank you.